A very good evening to one and all. My topic for discussion today is importance of optic nerve head analysis in detecting glaucoma progression. So why do we need to examine the optic nerve? Because it is the site where the damage due to glaucoma is most prevalent or most seen. So optic nerve is nothing but a bundle of axons of retinal ganglion cells as it exit from the retina to the brain. So the goal of examination of optic nerve is to distinguish a normal optic nerve from an abnormal one. If it is abnormal, we have to distinguish glaucoma from other optic disc pathologies, and if glaucoma is present, we need to detect and watch out for progression. So the gold standard for examining an optic nerve is stereoscopic viewing with the help of a slit lamp and fundoscopic lens. It's always ideal to dilate the fundus and to obtain a fundus photograph so that we can compare it with the previous visits. So with the help of a slit lamp, we make a small vertical beam and overlay it over the disc. And the length of the beam is multiplied by the correction factor of each condensing lens to get the size of the disc. So what is a normal or a typical disc? So these are the basic characteristics. It has a normal or a vertical disc diameter averaging between 1.7 to 1.8 mm. The disc is vertically oval, whereas the cup is horizontally oval. The rim follows the Eisen rule, and the rim is yellowish orange or pinkish yellow in color. The discs are similar or they are symmetrical in both the eyes. The central retinal vessels arise slightly nasal to the center, and there are visible RNFL striations superior and inferior to the disc. So size is the first factor which we take into consideration when we examine the disc, and this is also the factor that varies the most. So naturally, a bigger disc will have a bigger cup and a smaller disc will have a smaller cup. So when we discuss about cup-disc ratio, it is of paramount importance that we have to consider the size of the disc. And also when we say that cup asymmetry is a sign of glaucoma, it is only if the discs in consideration are of the same size. So based on the disc diameter, the disc can be classified into a small, medium and large disc. So cup disc ratio is nothing but the ratio of the vertical cup disc diameter upon the vertical cup diameter upon the vertical disc diameter. But to identify this, we need to know what the margins of disc and cup are. So to define the margin of disc, that is done by identifying the scleral rim of Elschnig. So the optic disc actually starts from the inner border of the scleral rim. Now the cup edge or the cup border can be found out by two methods, that is by color contrast method or by contour method. By color contrast, we typically mean that there's a difference in color between the cup and the rim. The rim is yellowish orange and the cup is pale in color, so we can identify the edge using that. But a more accurate way would be a contour method wherein we trace or trail the blood vessels. So as the blood vessels come from the optic disc, they bend at the edge of the rim of the disc. So if we trace all the bends of the vessels, we will be able to get the edge of the cup. Second one is neuroretinal rim, and this is basically the area between the disc margin and the cup margin, and it is formed of 1.2 million retinal ganglion cell axons, which leaves the optic nerve head. So the rim, which is made up of axons, it is orangish or yellowish in color, whereas the cup, which is a void area, it reflects the lamina cribrosa underneath and it is pale in color. So in a glaucomatous disc, even though the rim gets thinner, it retains its color, that is that pinkish yellowish color. The only exception to this is when the disc endures an acute rise in intraocular pressure, such as in case of acute angle closure glaucoma. So rest assured, in almost all glaucoma cases, pallor is not there. And if at all we encounter significant pallor of the rim, or if the pallor is more than the cupping, we have to think about other causes of optic neuropathy. So next is the Eisen rule, which means that the inferior rim is thicker than the superior, which is thicker than the nasal, which is thicker than the temporal. So the neuroretinal rim thinning can be diffuse or localized, and a localized defect is called a notch, and when there is a complete loss of an RR tissue, it's called excavation. So we all know that the glaucomatous rim thinning usually affects the superior and inferior poles. We do not come across a nasal or temporal notch superiorly. So why is it so? The answer lies in lamina cribrosa. So this is the cross section of the lamina cribrosa, and it has fibrous tissues called the glial cell which support the axons. So if you look at it closely, the pores in the superior and inferior area, the pores are larger. The size is larger, which means the support to the axons are less, which means the axons becomes more susceptible to the damage due to rise in intraocular pressure, resulting in a notch superiorly or inferiorly. So as far as progression is concerned, there will not be any change in the size of the disc, but there will be progressive increase in the size of the cup or the cup disc ratio. Why? Because there is progressive thinning of the neuroretinal rim, initially maybe in the form of unipolar notch, followed by bipolar notch and an excavation of the rim. The next one is the retinal nerve fiber layer. They are nothing but refractive striations extending radially from the disc. They are thickest and most visible superior and inferior to the disc. So when we visualize them in a red free filter or a green filter, they are seen as white lines against dark background because these thicker striations reflect the maximum amount of light. So the RNFL defects can be slit defects, wedge defects, or diffuse defects. Diffuse is anything more than 30 degree. Again, when we look out for progression, we have to look out for progressive enlargement in the size of the RNFL defect and also development of a new RNFL defect. So there are many vascular changes with varying degree of importance when it comes to glaucoma. We will discuss a very few of them. So first one is called the bayoneting of vessels. Bayonet is nothing but it's like a knife or a dagger which is attached to the end of the rifle so that the soldiers could defend themselves. So this is the normal arrangement of vessels in the optic nerve. This is how the central retinal vessels comes out through the optic nerve. But when there is a cupping or deepening of the cup, these vessels will have to take an acute bend at the edge of the thinned out NRR. This is similar to the bending or kinking seen in bayonet, which is why it is called bayoneting sign. Next is bearing of circumlinear vessels. Circumlinear vessels are small vessels which are branches of central retinal artery that runs along the rim of the edge of the cup. So when there is an enlargement of the cup, the circumlinear vessel stays in that position, whereas the cup margin will recede further. So this will make the vessel look bare or exposed or as if it's lying on the surface of the disc. This is called bearing of circumlinear vessels. Nasalization of vessels is not very specific to glaucoma. It can be seen in normal discs also. Next is disc hemorrhages. They are basically splinter hemorrhages seen usually in the superior temporal or inferior temporal quadrant. They usually resolve within few weeks to months, and when they resolve, it's usually associated with a new RNFL defect or an early notch. So in a diagnosed case of glaucoma, if we encounter disc hemorrhage, it is a strong predictor for progression of glaucoma. So while analyzing the vessels for progression in glaucoma, we have to carefully look for shifting of vessels because vessels shift only when there is a thinning of neuroretinal rim or there is an enlargement of cup. So documentation using fundus photo is of paramount importance in glaucoma. So in presence of a disc hemorrhage or trans hemorrhage, we have to watch out for RNFL defect or an early notch. The next one is peripapillary atrophy. There are basically pigmentary changes in the peripapillary area around the optic disc. There are two zones, the outer alpha zone, which is not specific to glaucoma, and an inner beta zone, which is specific to glaucoma. Normally seen in open angle glaucoma and normal tension glaucoma. So in progression, we have to look for progressive enlargement of the beta zone of peripapillary atrophy, and it's more common in myopic glaucomatous discs. So to summarize, these are the 5 R's which are important in the optic nerve head evaluation, which are the scleral rim, neuroretinal rim, retinal nerve fiber layer, region of peripapillary atrophy, and retinal or optic disc hemorrhage. There's also the concept of disc damage likelihood scale, which was put forward by Spaeth. This is a method of estimating the risk of glaucoma damage in an optic disc. But here we take into consideration the disc diameter and the thinnest rim width. So it is not basically cup disc ratio, it is rim disc ratio which is taken into consideration here. So what are the features of glaucomatous disc? It will have a large cup disc ratio for a given disc size. There will be an asymmetry of cup disc ratio between two discs given the size of the discs are same. There is NRR thinning. The cup becomes vertically oval. There is violation of Ising rule of the rim. There is vessel changes, there is loss of RNFL reflex or a defect, and there is presence or progression of peripapillary atrophy. The signs of progression are progressive increase in the cup disc ratio, changes in the NRR contour such as development or enlargement of a notch, shift in position of vessels, recurrent disc hemorrhages, progressive changes in RNFL defect, and enlargement of beta zone of peripapillary atrophy. Thank you.
Thank you. Thank you, Dr. Rinu, for the